wanted to clarify this, and I was trying to think of a nice way to clarify it without making it be so messy. So I decided what I was going to do. Okay. It's still here. It will still be on the exam, and I'm telling you that it's on the exam. That's compromise number one. Okay, we're going to walk through this, and I'm going to be very detailed about it so that y'all understand it, and you're going to be able to skip this when y'all are studying for the test because you're going to know it well. I'm going to give you the caveats though, okay? Remember always, whenever we're talking about diagnosing our patients, okay? Always, 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 they have to have lifestyle modifications. Everything is not going to be taken care of with us just giving them medications, all right? That's number one. So then they come in and we get their A1C or we get their sugar, their glucose levels back, right? So this is saying their A1C is over 6.5. At that point, we are going to set a goal for them. That is step one. So taking into consideration all of the things that we talked about, their age, any other comorbidities that they have, all those other things, we then take that into consideration, okay? We set them a goal. When we got that A1C back, if it is over 10, then you're going immediately to your insulin, okay? If it is not, then you can just give them metformin. But they're within 1.5% of that goal that you set at that point. If they are greater than 1.5% of the goal that you set, so let's say we picked 7 and I'm at 8.6, okay? I now need dual therapy. Dual therapy being my metformin plus one of these meds in that option 1 column. Sulfonylureas are going to be your very last line for anything, okay? They are old. Sulfonylureas suck. S-U-S-U-C-K, okay? Last line. Then you see your basal insulin. There's no line there because at any time while you're treating your patient, if they continue to go in the opposite direction, and now this is a conversation that is up to you and that patient to decide when are you going to pull the trigger and say, okay, you need insulin. Are they symptomatic? Are they not symptomatic? All of these things can blow this entire algorithm up. So on your exam, this is going to be a perfect situation where you're going to know how to walk exactly through this. Real life, this thing is all over the place and there's lines everywhere, right? Because people are usually going to have comorbidities whenever they're coming to you with diabetes. People are going to not be adherent. People are going to tell you that they don't want to use insulin when you're telling them to use insulin. They're going to have signs and symptoms that come and go. So all of this is very nice and neat, but in reality, your patients are not going to be nice and neat, most of them, okay? If they have a comorbidity, is it showing up on y'all's screen? Because it's like cut off on mine, and I don't know why. Hold on, I don't know why it's showing this to us this way. If they have a comorbidity, okay, that was where we were deciding the ASCVD or they had to lose weight versus if they had CKD or heart failure. I don't know why this is all the way down there like, oh my gosh. I see what happened. Hold on, y'all, the slide moved down and I have to move it back up. And now we can see it. You can see it, right? Because I was like, what? You cut off half of it? Okay. Remember, your P's cannot be mixed. So your DPP cannot be mixed with your GLP. Okay? So no P's together. DPP, GLP, not together. You're checking the A1C every 3 months because that is how often our red blood cells are dying, and our A1Cs are reflective of the life of that blood cell, okay? So that's why we're checking the A1C every 3 months to see if our medication is effective. How effective is my medication? Are we going down? Is my patient listening to what I'm telling them to do, okay? And then we wait another 3 months, and then we can add on another medication. Again, insulin is always an option for you. If they have ASCVD, or they're trying to lose weight, you see that we can use our GLP-1 or we can use our SGLT2 inhibitor. If this patient has heart failure or CKD, you see that we are going first line with our SGLT2 inhibitor. This is irregardless of their, or this does not, I hate irregardless, I hate that word. This does not matter about their glucose levels, okay? So if they're on metformin or not on metformin, if you see a patient that has CKD or they have heart failure, you can start them on an SGLT2 inhibitor. That is the idea of this. What I want you to remember is what is on this slide. You are adding this to metformin. So if I said, Raina came into your clinic, Raina had a A1C of 9, you're going to start, and I have heart failure. Please don't. And I have heart failure. I have heart failure. You're going to start me on metformin and an SGLT2 inhibitor. That is your second choice for me. If I came in and I was already on metformin, add my SGLT2 inhibitor. If I was newly diagnosed. So that's why I'm saying, like, this looks very nice and neat, but it's very messy and an art on how you're going to give it. So for us, if I have one of these comorbidities, I'm going to be on metformin plus this second medication. Okay? So if you see a comorbidity, are they on one med or two? Two. Okay? Yes.
With the 1.5 piece, are you going to tell us our goal, or is our goal always 6.5?
I'll tell you the goal. I'll tell you the goal if you need to go, yes. That's like if I want to be skinny. Or if they want to lose weight. Don't say that. Yes. Or if they want to lose weight. No. Yes. Yes. Or if you have a person who they are obese and you see that they would prefer, like they would benefit from weight loss, because remember, a lot of these patients who have diabetes, they also have other comorbidities. That's why we're watching out for heart failure in ASCVD events, because they're more likely to get them if they are diabetic, right? So if you're wanting them to lose weight without telling them, hey, I need you to lose some weight, you can also add one of these things on there to decrease the risk being elevated for a coronary ASCVD or any type of heart failure event happening in them, okay? Or high cholesterol, all of those other things, okay? All right, now y'all are going to have to tell me where we were. This one? Or were we at this one? This one?
Yep.
Okay, your maglitinoids, we're going to FYI all of these. We're not doing these. I like coming to class with y'all. Y'all make me laugh. Okay, the reason why we are not, let me tell you why. These are not in the guidelines anymore. You will see them. You will probably see some patients who are still on them, but they're similar to your sulfonylureas. It's just not something that's used often, and because of that, I don't want to test y'all on that because you're not going to use it, okay? So, FYI again, they are like your sulfonylureas. What did your sulfonylureas do? Like, what is one of the biggest side effects? Hypoglycemia is really bad with our sulfonylureas. So this class, what the idea was that they would cause less hypoglycemia, okay, but not helpful, and they're not in our guidelines. So again, FYI for this as well. FYI for this as well. Slide 98. Okay, your thiazolidinones are your insulin sensitizers. So they're trying to make your body more receptive to the insulin that occur once it is secreted. Okay, so insulin sensitizers. And then it's going to be more sensitive to that insulin to help with the uptake of your glucose for your muscles to actually use that glucose for energy. So you see that it binds to your PPAR gamma receptor, and that's how we're getting that increased sensitivity for our insulin. duh, for our clinical use, right? No. Okay, adverse effects. If you have somebody that is already overweight, you're probably going to want to avoid giving them a TZD because they can have some weight gain. The side effects for this class are pretty sucky. Also, the fluid retention, so if somebody is unstable, they have symptomatic heart failure, right? They already are probably going to be a little bit fluid overloaded, so we're going to watch out for giving them a TZD in that case. And then looking at the MI, specifically when you're looking at your resiglitazone, although they don't see an increase in the mortality, you see that we can increase the risk of somebody having an MI, which is not a good thing, okay? So this was a controversy a while ago, not something that we see often come up, but it is a thing. Increased fracture rate. So if I have osteoporosis, please don't give me a TZD because you're probably going to increase my risk of breaking. And then hepatic failure, and then the risk of bladder cancer. And think about bladder, you have to pee. PHARM. Remember that? Okay, so our precautions, we talked about this, heart failure. So it's a precaution if you're 1 or 2, class 1 or 2, but it is a contraindication if you are a 3 or a 4, okay? So just knowing the difference between a precaution, meaning I can give this to you, but I'm just gonna monitor you, versus I cannot give this to you, contraindication. All right, and then you see with someone who has bladder cancer, especially when you're talking about your pioglitazone, watching out for that because I could increase the risk of you having that bladder cancer occur. And then our interactions, if you are giving the resiglitazone with the nitrate, you see that your MI risk can increase. Just understanding that it is a possibility and that the risk of your heart failure is just increasing. That is the main thing with this. So with our thiaglitazones, watching out for our heart. So class 1 and 2, caution. 3 and 4, no. Caution also with our pioglitazone, with our bladder cancer. Monitoring. A1C, duh, we do that with all of them. The liver, because of the hepatotoxicity, always when we're drawing these things, we're looking at our baseline, comparing it to what we have after we continue to treat those patients. So when you're bringing them in every 3 months, just keep looking at that. And then your lipids, because of the activation of the PPAR gamma receptors and those alpha receptors, your body is going to be holding more of that, storing more fat is what could happen, which is how we're getting that weight gain as well. Okay, so thinking about the mechanism and those adverse effects, they go hand in hand. And then looking at your heart failure, remember we talked about this increased risk. Here are your 2 medications. I need for you to know the meds, and then you can just know what meds you have available. Okay. What else do I want you to know? Your Actos, because there used to be commercials that would come out and be like, if you ever use Actos, buy, and it told you the manufacturer, that you could probably have an increased risk of bladder cancer. So because of the controversy, you won't see this prescribed a lot, but there will be some patients who are still on it, and we still have it. It is still made. Okay. Incretin-based therapy. So your GLP-1, glucagon-like peptide agonist, and your dipeptidyl peptidase, DPP4 inhibitors. Essentially what this is doing, they're members of our the glucagon peptide superfamily, and essentially your body releases insulin when you have glucose. Like I ate some type of food and my glucose levels are now up. When you're looking at these charts that are on here on the slide, the top one is representing your insulin response to when you see the oral glucose, and then the bottom is representing the response when it's given IV. So one is like a oral response, and one is an IV, like us trying to mimic a response. And then what they saw was the effect in the type 2 patients who had type 2 diabetes. it was diminished. But you can see that there's a big difference when you're looking at the two different charts. So what we also found was that these hormones, they play a big role in like hunger, and they play a big role in us getting out that getting that glucose out of our system. Okay, so with this, you see they're degraded rapidly. So what we are trying to do is come up with a medication to last a little bit longer that have the same functions as these medications. So our GLP-1 is the way that these are working is it's kind of trying to tell our body, hey, food is coming, do something about it, let's use it. So when you're looking at your GLP-1 from our L cells, and what it is doing is in response to the meals. So if somebody is not going to have a meal, they should not be taking this, okay? Low risk for hypoglycemia, because as you see, it's only going to work in the presence of the glucose. If there's no glucose, it is not going to work. When you're looking at your GIP, these are your K cells. Okay, so these are your mechanisms, the L cell and the K cell. And then what it's doing is it is trying to alter how much insulin is being secreted out in response to that glucose that is now being placed in your body. So it's not doing anything with whether or not you're hungry, increasing or decreasing, I should say, your satiety, your hunger. Okay, so this has nothing to do with that at all. Whereas you see your GLP-1, it is slowing your gastric emptying, so therefore they feel full longer after they've eaten something. This is just a summary chart of the differences of what is happening, their actions, so like their mechanisms of what's going on. So after you've kind of looked at everything, go back and see what meds have these functions, okay? So it's just a summary of everything that was on the slides before that we've already looked at, so that you know the difference between the two and what's happening. Okay, so we were just talking about how our GLP-1 agonists are binding to that incretin receptor to mimic its effect. So they're called incretin mimetics, and your DPP-4s are inhibiting the DPP-4, which degrades the enzyme that's responsible for those incretin hormones. So when it comes to you like picking which one you're supposed to use, you're kind of looking at, do you want your patient to have weight loss? How much weight loss do you want your patient to have? Do they have a problem with eating? Do they not have a problem with eating? The route of administration, how would they want to take it? Do they want to inject themselves versus do they not? Because your DPP-4s are oral medications, whereas your GLP-1s, they have to inject themselves. So all of that will come into play. So just thinking about the difference between the two, a lot of patients initially will try the DPP-4s because they just don't want to do the injection. If somebody else is definitely more heavy on wanting to lose weight, they'll get more of that response from their GLP-1s. So just looking at the difference over what the patient is after and what their glucose levels are looking like and what is our target. Okay, so our GLP-1s, more effective, more weight loss, injections. Our DPP-4s, a little less effective, but they're not going to make them cause weight, and I can take these orally if I don't want to inject myself every day. Okay. Mechanism of action, essentially, we just talked about it, inhibiting our DPP-4 enzyme. So we're preventing the degradation of those enzymes that were being degraded very quickly. Now we're keeping our GLP-1 and our GIP around for a little bit longer. Okay, so that is essentially what it is: oral medication. Adverse effects, I'm not getting that much weight gain. You do see on here that it may be associated with our pancreatitis, so that is a big deal because we don't want that to happen to our patients. Low risk of hypoglycemia, again, very good thing because we don't want our patients to have hypoglycemia. Your sitagliptin or your saxagliptin, you see the increased risk of infection. So talking about our UTIs, upper respiratory infections, these things can happen to them a little bit more. They found this in studies, so looking at the fact that the respiratory tract and the urinary tract are getting more affected when we're giving our CETA or our saxagliptin. It likes to kind of sit in those areas, okay? What else? You see your saxagliptin worsening heart failure. We don't want to do that, okay? And then our interactions, if we're using this with the sulfonylurea, we saw this on the sulfonylurea slide that we would decrease that sulfonylurea dose by 50%. Pharmacology, just looking at these, here are your different medications. So I just need you to know the drug, and then looking at your comments on here, understanding just, again, I don't need you to know specific SIP names. I just need you to know, hey, is this a substrate, inducer, inhibitor, whenever you're going through these. And then your dose adjustments, read over them. Probably not going to ask y'all that because it's super close to each other. If it needs a dose adjustment, severe, like little itty bitty words, and I don't like to be that nitpicky. So look at your SIPs and see, are they substrates, inhibitors, all of that, but both of these are substrates, okay, when you're looking at your sax and your linagliptin. Yes?
You said you wanted to know one of those, if it's a substrate inducer or inhibitor. I'm not seeing it on there.
It just says substrate. It don't say substrate on y'all?
It says substrate, but you said.
I was just talking in general of like whenever y'all see SIPs, I just want your mind to always go to, is it an inducer, is it an inhibitor, is it a substrate, so you know what it's doing. Not this slide, they're both substrates, okay? But just in general, when y'all see stuff, very rarely will I tell you to remember exactly what it's SIP, because why? You can look it up, okay? Okay, so that's all I need you to know. Drug, SIP substrates. Which two are your SIP substrates? When you're looking at your GLP-1, we talked about this, but it does all the great things that we talked about. It's suppressing that glucagon secretion, it's slowing our gastric emptying, and it's decreasing our hunger. This all sounds great. They're also looking at different studies. That's why you see it italicized, where it says that the beta cell, stimulating more beta cells and preservation of those beta cells that we have left so that they don't progress to get insulin dependent is what that's talking about. So they've seen it in animals. I'm sure they're going to continue to study them as they get a little bit older. And then we'll figure out, hey, are they really using this? And then they'll probably move to something that's first line, because why would we want to make someone beta cells be burnt out? Okay, so just something to keep in mind. Adverse effects, hypoglycemia, we don't have a big risk, but it's there. Our normal things, right? Headache, nausea, vomiting, all those things that we see. When you're looking at your Lyra, Dula, and exenatide, you see the pancreatitis come up again. And then you also see that they're talking about the class as a whole. You have a possibility of the thyroid cell cancer. So when we look at these, remember which ones are causing different cancers, right? Because you see that's like a common thing that keeps coming up. Which ones are causing our pancreatitis? Like, these are common things that are coming up in here. And then which ones are big offenders for hypoglycemia, weight gain? Like, that's how you're going to sort these out so that you can kind of remember, okay, what am I using for what? Because if I tell you, oh, your patient is overweight. If I tell you, oh, your patient doesn't like to have injections. All of those things are what's going to come into play with what you're picking for your patient, okay? Contraindication, type 1 diabetes. Okay, because it's not going to be able to work on what it needs to work on. They need to have insulin. So that is almost a contraindication for most of these that we're talking about. And then if they have a family history of this thyroid cancer, then we don't want to predispose them any more than they're already predisposed. So that's why you see that listed there. Our interactions, it can delay the absorption of other medications that they're taking. Because remember, it's delaying, yes. Don't tell me something else is out of order.
On that last one, I was just gonna ask, for that renal insufficiency, is that all except for renal, or is that all? Because Lee was the one that didn't need to be renally dosed.
Wait, say it again. For what?
Renal insufficiency. There was only one that didn't need to be renally dosed. I was just wondering if that one was also included in the renal insufficiency.
So they don't have it linked yet so I have to use certain resources for these things, and I don't talk to you guys about studies that are going on. So right now, in studies, what it is saying is it's for the entire class. So just remember it's specifically for the class. Remembering your lira, your dula, and your exenatide for your pancreatitis, those are the only ones that are specific. Everything else, remember it as a class. Okay. I forgot what I was saying. Oh, so because we're delaying the gastric emptying on here, just remember that that may delay the absorption of other medications if it has to go through the process of metabolism and all that. Absorption, if I'm delaying how long you're staying, I'm delaying your transit. Now I'm delaying your ability to work. And then you see your, we talked about the sulfonylurea, decreasing the dose so that we can decrease the risk of our hypoglycemia. And then also monitoring those enzymes that we have for our pancreas. So you see your amylase and your lipase. That's the first time that we're seeing that we're looking for this. But on your other meds as well that we have that we just talked about, if they cause pancreatitis, we should be monitoring for that to make sure that we're not putting our patients into that situation, because that would not be good. And then also you have your possibility of having a better lipid profile, blood pressure profile, because again, we're decreasing essentially how much these people are eating, as well as giving them that little benefit of weight loss. So that kind of helps you with a lot of other things, okay? So that's why this is one of our first options that we had when we were talking about weight loss. You also see the difficulty swallowing or the neck masses because we're worried about cancer, thyroid cancer. That is why we're watching out for that to get ahead of it before it is a larger mass in those patients. Here are our different medications that we are using. What I need you to know here is these are all medications that we are giving sub-Q. Some of them are every day versus some of them being weekly versus some of them being given before you have your dose, okay? So your exenatide, you see that you're giving that twice a day before their breakfast and before their dinner, an hour before. When you're looking at your exenatide, this picture is showing you they got the medication from this, what is it called, a Gila monster? Or something weird, it had a weird name. But that's essentially where they got the name from, and so that's why that's listed there. It was something with the saliva that they used to get the medication. That's how our medication is working. So you see you have your weekly, you see these are not cheap. That's why you see these clinics popping up all over the place since everybody wants to be skinny and they don't have diabetes and they're using meds like this. They are expensive. They are not cheap meds. So that's why you also have been hearing a lot about that on the news, because people are using it more for weight loss than them managing their glucose levels. So that's that whole hype around that. With your lira, you see your lira is the one that you're taking every day, okay? Just be very cautious with some of these meds and understanding when you're going to pick them. So if I said that I had some type of CV risk or I had a history of a cardiovascular event, my lira is the one that I'm going to go to first. So your liraglutide or Victoza. You see that, and I don't need you to remember this, but they're giving a higher dose when they're looking at trying to target weight loss versus trying to target managing those glucose levels. So that's the difference that you'll see in a lot of these. The dosing is a little bit different. And this came about because they saw, oh, this is an adverse effect that's happening in people, which is usually how drug companies, I need to make like a drug company. That's how they make all their money. It's like, oh, this is a side effect and people like this side effect, let's call it something else and sell it to them again, okay? So just be very cautious and understand that these are things that are being used, not always for our diabetes management. What else did I want you to know with this? I told you about your lira is your everyday and that you're using that for your CDB risk. Your exenatide, I guess that is kind of important for you to know. Watch out for your renal. Okay, if it's less than 30, you don't want to use it. And then if they're at the severe renal disease or they're at the end stages, that makes sense, right? Their creatinine clearance is probably going to be very low as well. So just watch it out for that. Your amylin analog, suppressing the amount of glucagon that someone may have after they eat a meal, which is normal. So this is trying to say glucose is too much. We're going to try to suppress you. Increases the satiety, so that's why people have the weight loss, because they feel full for a longer period of time. And then again, that's associated with the fact that it's slowing that gastric emptying. Okay, so improves the rate of glucose appearance in the plasma. Type 1 and type 2, meal time. I have to have the glucose there for it to work, right? Meal time. Prior to our meals. Again, I just need you to know that it's sub-Q and that we're taking it at meal time. And we can use this as an adjunct to our insulin in our type 1 diabetic patients. Sorry. So this is just showing you essentially how your amylin works to suppress the glucagon secretion, and it's decreasing the hepatic glucose production. So essentially in our stomach, it's increasing how long we're feeling full and decreasing the amount of food that we're intaking. So that slowed gastric emptying is how we're seeing the side effects of them having that weight loss. They appear to be full longer, so people who like to eat a lot, they're not going to eat as much. So that's how we're getting our decreased glucose levels. That's all the picture is telling you. Another summary slide against the other medications, our GLP-1, GIP that we already talked about. So again, if you want to see this on a nice clean slide picture, here it is again. Our adverse effects, hypoglycemia. Okay. If you are seeing that this is occurring, and if you are starting this because your patient is not controlled on their insulin and you don't want to increase their insulin dose just yet, what you could do is you could decrease that insulin dose by at least 50% if you're going to give this in addition to insulin, okay? And that should decrease your risk of having the hypoglycemia while having that added benefit or getting some better glucose control. And then you can, as you get your patient more stable and you start to see those logs are leveling out a bit, if the glucose levels still aren't looking great, you can slowly then titrate your insulin back up, okay? Nausea, this is also a big thing that they're trying to sue about now. They're like, oh, they didn't represent well all of the GI side effects that a lot of patients could have. Jump on the bandwagon and let's sue them. I was like, dang, I should have taken me some of this. Get me some money. Just kidding. So nausea, think about that though. Very uncomfortable. Over 50% of our patients are experiencing that. That's a lot. Okay. Contraindications, if they already have gastroparesis, we're not giving it to them. They're already slowed down. We're going to slow them down even more. They're probably going to have more side effects. They're probably going to be a lot more nauseous. Okay. If they have hypoglycemia a lot, this is a high offending medication for hypoglycemia. I'm not going to give it to them. It makes sense. They go hand in hand with what we are saying our adverse effects are. So you remember one, you know the other. And then our interactions, again, talked about this with decreasing our prandial, so our mealtime insulin dose by at least 50% if they're taking like a rapid on top of their basal. So if they're taking a bolus, we can decrease that bolus rate. And then if we see that postprandially, our patients are still not controlled when they're taking both of these agents, we can slowly titrate our insulin back up, okay? And then delaying the absorption, again, because of the gastroparesis that occurs, that is why we get that delayed gastric emptying that occurs with these. Here's our medication that we are using. Again, understanding that it is a sub-Q. We can use it in type 1 and type 2. Skip a dose if a meal is skipped. And when this is saying, like, don't mix it with insulin, like, don't, you know how we were talking clear to cloudy? They're saying, do not mix these two things because someone has an auto injector or they have a syringe for somebody to try to draw them up and give them to each other. Give them with each other, sorry, give them to each other, okay? So skip a dose if you skip your meal. If not, we have that high risk of hypoglycemia. We don't want that to occur. Your alpha glucosidase inhibitors, our mechanism is delaying the breakdown of those sugars, so our sucrose and our carbs to glucose. These are effective medications, not seen very often, but you can use them, okay? Reduction of our postprandial glucose, so that is what we're targeting. So we're targeting what their glucose levels are after they've had a meal. And then you see your glucose, lactose, and fructose absorption are not affected when you're taking these medications. We're looking at our sucrose, okay? Type 2, so if they're close, like they're fasting glucose, their fasting plasma glucose levels are close to where we want them to be, but after they have a meal, they're spiking high. This is what we are using for those patients. They don't need a lot of control, and the effectiveness of this medication for someone who's very outside of their goal range is so minimal. That's why we're using these specifically for, I'm having a meal and that's when I'm seeing most of my spikes. Okay, taken with the first bite, that's the first time that we're seeing, as I am about to eat my medication, eat my food, I'm going to swallow my medication, okay? So it could be like, hey, right before you have a meal, be careful with how you tell patients this, because people will like literally try to put it in their mouth with their food and bite it, and it's going to be disgusting, okay? So tell them right before you have your first bite of food, you can have this one. And you know how we were talking about our insulin and all of our other meds, where we were taking them 30 minutes or 15 to 45 minutes or an hour before? This one, I can do it right away with my meal. Okay, so if I eat, I need to swallow a tablet. They're going together. Weight neutral, which is good. You see a lot of GI discomfort that's happening. More with your amygdala than your arcabos, but again, they both have the same side effect. GI discomfort, okay, bloating, gas, just uncomfortable. Don't use it in our patients who have the short bowel disease or if they have IBS. Anything that's wrong in that area, contraindicated, don't use it. And then you see that when you talk about Beano, Beano gas, those tablets that people can use, it may help them with those side effects that they're experiencing, but now you're decreasing the effectiveness of the med, so it's kind of canceling each other out. So if they can't deal with the side effects, then you should switch their meds, is essentially what that is saying. Beano is not a good thing for you to try to give to them. Here are two different meds that we have. Looking at when you're not using them, right? So just your carbos, and if you see your serum creatinine level is over 2, then they are contraindicated. You can't use them. That's essentially it. Our SGLT2 inhibitors. So essentially what this is looking at is inhibiting that sodium glucose co-transport to transporter. Okay, so that is just inhibiting us from reabsorbing the glucose that we were trying to bring back into our body. So it's trying to make us excrete it more. Okay, so that's why you see the increased urinary glucose excretion. Our use type 2, empagliflozin, canagliflozin, those are the ones that you are specifically using when our patients have those CV risks. So when we go back to that chart that we looked at in the very beginning of class, these are our two choices. Our empagliflozin or our canagliflozin are the ones that we're using to reduce our CV risk. Potentially a class effect, but we know for sure with all of our studies that we've done that those two are the ones that are going to work. So when we're thinking about the fact that it is increasing how much glucose we're getting out, okay, we have some weight loss, you have the risk of that hypoglycemia, but when you see those genital fungal infections, think about sugar just sitting down there, especially if they don't have proper hygiene, they're not wiping correctly. So fungus loves sugar. That's how they're going to thrive, right? So that's why you see that increased risk of the fungal infections and the UTIs. So when we're talking about our SGLT2, think about sugar being excreted. Okay, so it's sitting in that area causing your UTIs and your fungal infections. More common in women, right, because we have more tight-fitting undergarments than most males would do wear. So that's why you see that. So our bacteria are just like, thank you for this. Breeding, breeding, breeding. I love you, SGLT2 inhibitors. Okay. Precautions. Dapagliflozin, bladder cancer. What was our other one that had bladder cancer? Okay. Renal dysfunction, don't use it. Okay, don't use it. You see that these have those weird cutoffs, so just remembering less than 30 or less than 25. But essentially, I just want you to know that you have those cutoffs. And then also something that's not on here that you should just be aware of with your canagliflozin, they may have an increased risk of stroke as well. So just thinking about that. Be mindful of our mechanism, okay? Our mechanism, they're working in our kidney. Our side effects, you have things where that sugar is sitting there, yeast infections, UTIs, bacteria love it, okay? And then these are just for you to look over, drugs that are increasing our blood glucose levels, okay? So the drug class that we have are beta blockers, corticosteroids. Our beta blockers, you have reduced insulin sensitivity in the secretion, okay? So that means insulin resistance. And then when you look at our corticosteroids, reduce insulin sensitivity. And you see this is after a longer duration that the medications have been on board. Okay, so it's taken a while for it to actually be like, okay, I have hypoglycemia. Some patients will see it very early on. If your patient is one of those patients, just make sure that you're adjusting their insulin dose and letting them know how to adjust that insulin dose. So make sure they have their sliding scale that you're going to give them so that they know exactly what they're doing if you're going to start them on a corticosteroid while you're managing their insulin. Okay, so yes, typically hypoglycemia may happen after a couple of months of being on a steroid, but it can also happen that very first day that you give me that steroid. Okay, sliding scale for these patients. Our other medications that we have that could increase our glucose levels, so our thiazides, again, almost the same way as our beta blockers. So just let them know what the hyperglycemia may look like. And then your niacin, same thing, increasing our resistance as well as the hepatic gluconeogenesis, so that's making more glucose, which we don't want that in this situation. Okay? Let them know what hypoglycemia is so that they can watch out for it. That is it for this. Now, what I wanted to do, and pick up, is this y'all's thing? Yes. So we finished, we did thyroid already, right? Did we do the review for thyroid? We didn't. Okay. So do y'all want to let's take our break. Let's do, it's the one that's up that says final, I think, in parentheses, okay? So HPA axis, what's going on here? Hypothalamus pituitary thyroid axis. You're seeing all of the different hormones that are and where they are working and where they are released from and where your negative feedback is coming from. Looking at our T3 and our T4, understanding that these are secreted to go into all of the tissues in our body to perform the actions that we need it to perform. If it is bound, it is not active. We can't do anything with it. Also looking at the fact that if we have any issues with our thyroids, these hormones are very, very important with metabolism and growth. So if we don't have them, then that's how you see mental as well as growth retardation that occurs. And then With our adults, that's why you see fluctuations depending on what type of hyper or hypothyroidism they may have. You'll see different fluctuations with their weight, and they'll come to you struggling with weight loss and things like that. Check their thyroid. This could be our problem. Okay, this was just showing you the different symptoms between your hyper and your hypothyroidism, understanding essentially what's going on with your TSH, if it's up, if it's down. I don't need you to be that specific, just a general overview of when you have hypothyroidism, usually what is happening is your T4 is down. When you're having hyperthyroidism, usually what is happening is your free T4 is up. That is the big idea there that I want you to know, as well as what your side effects are, depending on what presentation your patient has. This is showing you the different types. So when we're looking at our hypo, which means that our free T4 is down most of the time, you have your primary, which is your Hashimoto's, which is that autoimmune disease where your body is attacking the thyroid. And then you have your secondary, which is coming from a hypothalamus or the pituitary issue, like there's some type of insufficiency there that is occurring, and that's why our levels are incorrect. It could also be because of us giving a medication to a patient that has now induced them into becoming a hypothyroid patient. This was all of our different signs and symptoms. We had that toxic goiter, big neck. And then we also had where they're cold, they're usually thinner, things are more brittle, like they're not well looking, they're tired, they are just trying to make it, okay? Remember your picture, he's like, oh, help me please. Cold, cold, cold all the time, okay? Our meds that we are using, you see that our main drug that we are using is our levothyroxine. That's the one that we said was our synthetic T4. And remember that our T4 can be broken down into T3. Dosing adjusted every six, usually to 8 weeks. So making sure that our medication is working before we actually change a dose. Monitor, of course, our thyroid levels. Are we being effective? How are the patient's symptoms? If they're still having symptoms, then I may need to increase my dose to supplement the T3 or T4 levels, okay? So that is what is happening with our meds. I think, let me just go back because I'm thinking of it right now. When you're looking at this as well, when we were talking about the animal sources, the desiccated thyroid, remember thinking about people who don't eat pork, okay? And also thinking about the fact that, like, if they're a person who's usually allergic to things, they may become allergic to this. And also the smell is very, 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 like, it smells like a pig. And so if someone can't get past smells of things, this is also not a pill that you would want to do. Also understanding that the pharmacy, when we get these meds, we get a different manufacturer all the time, and some people will not respond to different manufacturers of these medications. So Synthroid is usually your safest bet when it comes to monitoring or treating your hypothyroidism. But these are all options that you can see. So I need you to know all of the options that we have. Our medications, this is just looking at the adverse effects, right? So if I give too much, now I'm making you hyperthyroid because I'm replacing those free, our T3 and our T4. Okay, so you'll see that you can go the opposite way. Our interactions, just want you to look through those. Understanding decreased absorption could potentially make our warfarin not as effective. Okay, so you see a decreased, oh my gosh, not as effective. Makes it more effective. So you'll see more anticoagulation occur. Sorry, that's what I'm trying to say. Interactions, again, just look at these, be familiar with them, and understanding that we'll need to spread them out when we're talking about certain medications, proton pump inhibitors, all of those things. And then the low cost and the long half-life. Synthroid, specifically talking about your levothyroxine, if you have a patient that comes into the clinic and they haven't taken their medication for a couple of days, usually they're okay because of that long half-life of your Synthroid that you have. So that's also a good, another reason why you pick this medication as well. here are your different meds, understanding your medications that you have. All of these, for the most part, are oral. You do have injections for your levothyroxine as well as your liothyronine. And then paying attention to our older adults and the ones who have the cardiac disease, you see that we're starting with that lowest dose before we increase in those patients. And then looking at the comments. Please look at the comments. Hypothyroidism, our state of emergency is a myxedema coma. So looking at what we would do with these patients, make sure that we treat it, because if we don't treat it, they can lose some of their brain function. Looking at the causes that could occur, like make this occur, and then our presentation, okay? So now they're even more lethargic, they're confused, they're very weak, they may or may not be awake, okay? Shock, death, all of these things eventually happen to them. So we're gonna give them IV levothyroxine, especially if they're not awake, and then that hydrocortisone until we get that, until we can rule out the adrenal suppression. So this is when we talked about you would give the hydrocortisone first with the levothyroxine to make sure that we don't replace it too quickly and put them into adrenal suppression. Different protocols say different things. Some people are like, yes, you can give them that IV and then give them the hydrocortisone. Just know that these are the two meds, because your installation may have something different as to how they choose to do their protocol. Hyperthyroidism, we said that usually the free T4 is going to be higher. This one, they have the toxic goiter, okay, Graves' disease. And remember, they have the ex-ophthalmos. Their eyes are like, they're bulging out. Remember, I told you don't look at your patients with your eyes open too, okay? Your thyrotoxic crisis or your thyrotoxicosis, when you have too much of that hormone, okay? So all of this is an excess of the thyroid hormone, and my body is going crazy. I am, like, my metabolism is up. I'm all over the place. I'm turned, okay? Thyroid storm, a storm, just think about the hecticness, okay? Life-threatening medical emergency, the difference opposite of our myxedema coma, and then you see all the things, tachycardia, they can't breathe, delirium, coma, same thing, nausea, vomiting, all that good stuff. Our symptoms, hyperthyroidism, you see the eyes on the cartoon, you see that he has a fan, it's hot, he or she, I can't tell, whatever, it's hot, okay? So just looking at that, increased blood pressure, diarrhea, everything is sped up, okay? Hyperthyroidism. These are all of the different medications or procedures that we can use depending on how we choose to go about it with the patient, okay? We have our medications, which are your thionamides. You have your iodides, which you give to temporarily block the release of your hormones. So if you're going to do surgery, or if we're trying to double, like kind of stack these things on when we're talking about our thyroid storms, that's when you'll see this used. Your radioactive isotope, we are trying to kill the gland, okay? So they're gonna swallow that pill and kill their thyroid gland. They may end up becoming hypothyroid with this. All of these options can make the person have hypothyroidism. And then your adrenergic blockers, these aren't necessarily treatment. We're just trying to help with those symptoms, okay? So if I'm giving them a beta blocker, I am just trying to slow down that tachycardia that they're experiencing, because remember, everything is turned. There's a storm going on, okay? Bless you. With your surgery, treatment of choice, if it is very bad, let's just get rid of the problem. Let's get it out. Depends on the patient. You see that pregnant women, we can do this in our pregnant women. For this to happen, it has to be very, very, very bad, because nobody is doing surgery on a pregnant woman. Their leg can be falling off, and they're like, can you wait until the baby comes out? You 9 times out of 10 are like, they would have to be very, 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 very bad for you to do this. But for your exam, no, pregnancy is there as an option for your surgery patients. And then remember, most invasive, because we have that scar, we're going to have to put them out for surgery. When you're looking at your radioactive iodine, non-pregnant females over the age of 21, make sure that they're not around anyone who is immunocompromised. Also, it's good for those who have that goiter as well. And then making sure that they don't have the ophthalmosis because of the ophthalmos. Because of the fact that this medication can further cause it to come out, that is why it is a caution. Some providers will still use it, just so y'all know if you do see it. Most cost effective, don't give it in our pregnant patients, okay? Or if they're breastfeeding. And then your anti-thyroid pharmacotherapy, this is like those patients where they're experiencing symptoms or they have a small goiter that we know that we can get to, and we're trying to maintain that size that it is at so that it doesn't get larger, for us to try to go in there if we need to and either get it out with surgery or us try to maintain it with these meds for at least 12 to 18 months. And if that doesn't work, which again in 50% of these patients it doesn't work, we can use them to bridge us to when we're going to do the therapy with either the iodine or the surgery, up to the patient. So usually the way people try to go about it is 3-2-1 if they are more of a mild patient. If they're a severe patient, they're usually starting at 1, and hopefully they don't have to get the surgery again, but it is possible that they can get the surgery again if we don't completely remove it. Yes.
First of all, you said we're just not doing pregnant women for surgery.
I said, in real life, most people are not going to do surgery on a pregnant woman unless she is like dying, okay? So if I told you on the exam, like, she is in this horrible thyroid storm, blah, blah, yes, surgery. But if I would not just tell you, oh, there's a pregnant patient, what is your choice to treat this patient's hyperthyroidism? Surgery? Like, no, that is not real life. I would not do that. So I would tell you that she is very, very, very severe for us to do surgery on a pregnant patient. Yes.
And the second bullet under radioactive iodine.
Yes. Because of when you give it, the medication can cause it to be more exaggerated. So it's like a side effect of giving them the iodine. So you don't want them to have a worse off appearance than that sounds bad. You don't want their appearance to be exaggerated. I didn't even say worse off. You don't want their appearance to be exaggerated. So that is why we are using caution in that. No problem. Your thionamides, these are your medications, understanding your mechanism, looking at your methimazole and understanding that this is our preferred agent unless they're in their first trimester. The one that you can always use for pregnancy was your PTU, okay? Thyroid storm, drug of choice, thyroid storm, drug of choice. Looking at your efficacy, seeing that it takes a while for it to work. So if we need to give them a beta blocker, give them something else to kind of help bridge them until they're getting the effects of these medications, that is what we want, 4 to 6 weeks for it to actually fully work on these patients and for us to see our response. So you shouldn't really be changing their medication until that happens. If they're still continuing to experience side effects or you see that their side effects are getting worse, you can slowly titrate these medications up to get the response that we need. You see your methimazole is more potent than your PTU, so you see that you're going to, with your methimazole, usually patients like it because they only have to take it once a day. And then that PTU, we also had the liver failure. So our PTU, drug of choice for our pregnant patients, also our drug of choice when we're talking about a thyroid storm, and we can have the liver failure occur with our PTU. It's weaker than our methimazole, okay? Monitoring, looking at our effects, how is our patient doing, monitoring our levels, getting the LFTs, remember, because that is a possible side effect, getting our CBCs, because we can have that granulocytosis. Jaundice can also occur. Discontinue your thionamide at least 3 to 5 days before you administer that radioactive iodine, and that is because of our mechanisms that we had gone over, so we don't want one to block the other, so that's why we're doing that washout period of the 3 to 5 days. Our adverse effects, looking at our black box warning, liver failure, make sure you remember our black box warnings because we don't have a lot of meds that have it. Jaundice, granulocytosis, we kind of talked about these, but the things that we're monitoring, those are our adverse effects. Cell lines being affected, you see our leukopenia can occur. Arthralgia, the lupus-like syndrome, okay, so they're going to have like joint pain, discontinue the therapy if they have that happen. This is a summary to show you the 2 meds that we talked about. And then the comments is what I need you to look at. And then you see that the remission rates, again, you can have them happen. Some providers can put the patient back on it for a longer period of time if they're trying to prolong when they need surgery. It can happen. More often in surgery, or in our smokers, in our patients who have those large toxic goiters, that you'll see that relapse occurring. Iodine, this one is the one that we're using to kind of help us destroy essentially that thyroid tissue, and then it takes a while for this one to work as well. So discontinue our anti-thyroid medications at least 3 to 4 days before we give this, which is what we had just talked about. You have your adverse effects, nothing very crazy there. The metallic taste, okay, is a thing. Looking at our 2 meds that we have, they're both PO'd. Sometimes you'll see them as little drops that they can put in. The comments, I don't really need you to know that, but you should know that the comments, they're there, okay? Looking at your lithium, and that we have our drug interaction with our lithium because it decreases the thyroid function, okay? So you can cause the lithium toxicity in those patients. Remember, it's a narrow therapeutic window, so be very careful when we talk about our lithium with our iodine. Our radioactive iodine accumulating in the thyroid, destroying that thyroid tissue. Remember, we can give it to that patient. They're going to be radioactive for about a week, but they're not going to see those full effects until 2 to 6 months have passed, okay? So you should slowly start to see their symptoms get better. We can still give them that beta blocker while they're doing this treatment. For the most part, they shouldn't have to have multiple. Don't give it to our pregnant women. Don't give it to our nursing women. Make sure that they're not around the other people who are going to be immunocompromised. If they have severe issues with their eyes, you see that we're not going to give it. It's not a, so this is like a back and forth thing that they're going about. Will it make their eyes worse off than what they already are and how they're presenting? Adverse effects, hypothyroidism, which we said with all of these meds can occur. We already talked about this several times. So decreasing meds before, lithium may prolong the retention of that radioactive iodine, so be careful with that. Here are our medications that we were using for our beta blockers. This was only helping us with our symptoms. This was not doing anything as far as fixing the hyperthyroidism. This is just helping with the symptoms that I have. If I am not able to use a beta blocker, you see I can use my non-DHB calcium channel blockers that are there. Your verapamil or your DILT. Look at your comments, look at your meds. Your thyroid storm, how am I treating this patient? They come in, they're hot, they are delirious, they could be pooping all over your waiting room and you're trying to help them. Oh no, you get your blood work back, you see that they have a thyroid storm, hyper, okay? So suppressing that new hormone synthesis that they have. Okay, your medications that you can use there block the release of that thyroid hormone that the body is still going to be making. Then we're going to help them with their side effects that they're having. Okay, and you see that your propranolol is the one that's more commonly used because it can also possibly block the fact that the T4 that's already out and absorbed in those tissues, it can block it from potentially being converted into T3, which is what has a lot more of our action. Giving them some Tylenol, help them with that fever, help them decrease their blood pressure a little bit. Corticosteroid therapy to help them with those vasomotor symptoms that they're having, sweating and all of that good stuff. And then, again, making sure that we don't hit them into that adrenal insufficiency that could occur. And then our bile acid sequestrants so that we can decrease the recycling of that hormone. We are trying to get it out because we are in a hyper state, okay? So we want to get rid of it. So that is why we're now using our bile acid sequestrants, which usually decrease absorption of things. We're using it for that purpose. We're using it for our good now. Our hypothalamic and pituitary medications, okay? This was a summary of what our HPA axis looks like. How does all of it work from our hypothalamus? releasing that CRH to our anterior pituitary, which then will go down to secrete the ACTH, which then acts on our adrenal cortex to produce the cortisol. Cortisol has that negative feedback system that will go to the anterior pituitary or the hypothalamus to say, I'm good, I'm happy, I don't need anymore, okay? So that is how everything is happening. This is letting you know when we're talking about our drugs and where they are coming from, the hypothalamus hormones versus the pituitary hormones. This is letting us know kind of what's going on and what effects we could expect from them. This is a summary of your hypothalamic hormones, remembering your growth, your GHRH, your somatostatin, which is doing the opposite of your growth hormone. It's stopping the body's growth, okay? Thyrotropin releasing hormone, corticotropin releasing hormone, GNH, RNH, which are LHRH, and then your dopamine, which is your prolactin inhibiting hormone. And then knowing the difference between what is coming from your anterior pituitary versus what is coming from your posterior pituitary, okay? Know where everything is coming from, where your hormones are coming from. This was just to show you all of the chaos that you have learned when you go through all of these slides, okay? Nothing in particular that I'm looking for here. This is just, again, going through the cascade so you can see where everything works. All right, this was just talking about the difference between, remember when we were saying our pulsatile secretion, which would stimulate, versus our sustained, which would make it like downregulate, stop, and we get over it. Okay, it'd be like, okay, you keep dancing at the party, I'm over you like you're too much. Overstimulating, versus every now and then you do a little jig, like, oh, I'm looking at you, I see you over there, girl. Kind of like that, okay? So knowing the difference between pulsatile versus sustained non-pulsatile or continuous, okay? Looking at what is our FSH and our LH4 in men and women, knowing the difference between those. This is just talking about an analog. Analog is an agonist, so it is trying to replicate the normal hormone that we see in our body. Our adverse reactions here, our adverse effects that we saw were a lot of sexual dysfunction and those vasomotor issues happening. So just think about these as like our sex hormones, okay? And then knowing how they're giving it suppression versus, so continuous for our suppression versus our pulsatile, which is going to stimulate. Clinical use, what am I using them for? Infertility, puberty, also when we talk about our when we talk about prostate cancer, okay, ovarian suppression, so sex hormones when we're talking about these. Looking at our approved uses, we talked about which ones you would use in your prostate cancer versus your endometriosis, and understanding that you had your Nefarlin for your precocious puberty, or those patients who are hitting puberty early, and we're trying to suppress all of those things that come along with them in puberty. So let's say I had a 6 or a 7-year-old that was already going through puberty, Nefarlin. No, you're too young. We're trying to avoid it. Remember though, as soon as you stop giving this medication, everything that was naturally happening in the body will come back. Okay? So these effects that we are getting are only in the presence of the medication, especially if it's important for us to give it in a continuous dose for it to suppress. Okay? Looking at your agonist versus your antagonist, and understanding that with your agonist, with that initial stimulation, you had the clinical flare, whereas with your antagonist, it was complete and immediate suppression, and so we didn't have that flare, that surge, because the testosterone didn't peak up like that for us. May cause a temporary increase in our PSA when we're talking about our agonists. Understanding your mechanism, looking at your agents that you use. What else did I want you to know from here? Looking at if you're having those clinical flares or not, and how you're giving it, okay? I think that is all I want you to know. So we're trying to prevent the patient's body from having that testosterone be secreted. So that's what we're doing, because if we have testosterone when we're talking about the prostate cancer, that's how the prostate was growing, which we didn't want it to do. So we're trying to suppress that from happening, okay? Understanding which ones are for men versus which ones you can use in women, okay? This is a summary showing you all of the different meds, what they're doing, and how they are being inhibited. So for instance, if I had growth hormone, it is telling me that I need to grow. GHRH is what is being stimulated from the hypothalamus. And then you have, as those levels start to increase, the somatostatin is what is telling your body, I don't need any more of this growth hormone. Stop it. Okay? So your last column is how you're turning off your first column from doing that second column, which is the action. Okay? So that is what is happening. Your first column is your hormone that is causing that primary function. And whenever that function, we get whatever we need to out of it. If it is too much, what have you, we then have our primary secretion inhibitor, which can go back and shut the whole thing off. Acromegaly, everything's too big, okay? Remember, it's bigger. Looking at our goals, what we're trying to do, we want to make them more comfortable. We want to decrease the mortality that they have and stop that growth hormone, that IFG or IGF from causing more growth, okay? So we're trying to inhibit. If it is a tumor, which we usually hope that that's what it is so that we can remove it, we can stop this from occurring. We have our pharmacotherapy that we can use, and then here are our agents that are for our pharmacotherapy. This is just, again, showing you which meds that you have, how they work, so be familiar with our mechanism, understanding the clinical use for them. So just put like what your clinical use is and what meds go in there, okay? Or you can use that very first slide that showed you all of the different hormones that were secreted depending on the area. So hypothalamus, anterior, posterior, pituitary, and then put your clinical uses so you know what meds you have to use in those areas, okay? And which meds fall under that class. So make that table can get very big, okay? So this slide, you can write clinical uses on here for all of these, and then you can write the meds that fall into each one of these categories, okay? So that you'll know where everything is coming from, which meds are coming from those areas, and what actions they're causing, which will tell you your clinical uses. Your octreotide and your lanreotide, understanding which ones you can use for what indications, okay? Adverse effects are there. Growth hormone deficiency, so the complete opposite. Instead of being too big, now you're too small. I think about big. I'm big, you're small. I'm smart, you're dumb. What movie was that? Was that big? Matilda. Her daddy was mean. I'm like, took the carrot. So now this is the opposite, right? I'm big, acromegaly, now you're small, okay? So this, you have more of your somatostatin is going to play a bigger role when we're talking about this. But again, our growth hormone is required during our childhood for our brain, body, all of these things to grow. So if we don't have enough of it, then that's when we have that growth and mental retardation that can occur. Our agents are the ones that are down at the very, very last line. Remember, this is the one that people could also use more to increase their muscle mass, so the potential of abuse in this one. Looking at your ACTH or your corticotropin, understanding what our mechanism is for this and our clinical uses are very important here. Remember when we were talking about our primary adrenal versus our secondary adrenal insufficiency. So when we're talking about our primary, we were like, no matter how much you try to crank up the car, it's not going to work because it is destroyed, okay? versus when you're talking about your secondary, there's some type of issue within that HPA axis that's occurring, and we can give different meds to see what's going on and figure out where our issue really is. This is our FSH, LH medication that we can give to induce ovulation in our women who would like to become pregnant, or our men who have low sperm count. So this can be used, remember which ones are for men versus which ones are for women. Also, very well tolerated, this medication, because they're injections, you just gotta usually worry about that. But for the most part, not too bad. Sex hormones, okay? All of these end in tropin. Tropin. Hyperprolactinemia, dopamine agonist, okay? So dopamine will shrink that prolactin secreting tumor that could be causing the hyperprolactin. So that was the one that we talked about where, yes, you could be getting that excess prolactin secreted, and as that dopamine level increases, it will go back and shut off that tumor to say, all right, we had enough, okay? Oral medications, your bromocriptine and your cabergoline, looking at the difference between those doses, understanding what we are using it for, okay? They're making too much prolactin, and it could be possibly from a tumor. A lot of these things that say hyper are from tumors secreting too much of that hormone that we don't need. ADH, remember, I was skating. Remember her. We're trying to balance that sodium release. So depending on how hyper or hypo or hypertonic, specifically looking at our sodium level, what is happening with our ADH in those instances, and then looking at if we have water loss, right? So if we have hypovolemia, hypotension, depending on what's going on, depending on if we're hitting our V1 more, so our blood vessels versus the V2, which were on our kidneys because we had 2 kidneys, what is our ADH doing, okay? So we're trying to essentially with ADH absorb more water, retain more water. So think about if I'm sweating, I'm losing it. I want my ADH to kick into play to get some of that water back for me so that I don't dehydrate. I want to keep skating. Oh, and I wanted you to remember your, it's not on this slide, it's the next slide. It's in this slide, somewhere in the treatment. I'll get to it. So our mechanisms, understanding where it works, just touched on it. This picture is a good indication of how that works as well. So understanding your mechanism, understanding that your adverse effects, if I had too much of it, right? If I retain too much water, what is happening? Now I have I'm with the water intoxication, and now I've diluted things out too much. So you'll see hyponatremia, and then don't immediately think for you to go and correct it. It could be, hey, this patient has some type of issue going on, which is when we were talking about our SIADH, which we'll talk about in a minute. Our agents that we have are your desmopressin, so your DDAVP. You see that we have different formulations, your injection, your nasal, and your tablet. That is important for you to understand. Minimal pressor activity, which is good, because we talked about how they clamp down, and then you will have to amputate on those patients because we clamp down too much. What else? That's it. So our clinical use, you see that we're treating our central diabetes more so with our desmopressin. You have your esophageal varices because they're bleeding. And remember, we have the action on our V1. So we can cause some constriction to help reduce how much that blood is, how much they're bleeding from those varices. So that's the mechanism for that. Managing their shock, okay? Tried epinephrine, didn't work. Now you can move on to your ADH medications. And then you see that there's not a lot of people that are going to use vasopressin for your asystole. I don't need you to get all into it. Just understand it's not a drug choice. I'm not asking y'all about any of that because that's not what we're talking about in this block, right? So if you see anything with this, you shouldn't see anything with this is what I'm trying to say. So that bottom one you can kind of cross out. Your SIADH, This one was, remember, I'm not properly managing what I'm doing with my water. And so you have your hyponatremia or your hypoosmolality because of the fact that you're retaining more water than you should be inappropriately. Your body is not telling you to do it. There is a malfunction, okay? And so you're trying to make sure that you can treat this condition or at least discover that this is occurring in the patient and correct it if you can, okay? So awareness that the hyponatremia is from the excess of water rather than this patient is actually deficient in the sodium, okay? So it will be an emergency. We don't want to overcorrect quickly because we can cause that CPM to occur, right, the demyelination. So I need you to remember how we're slowly raising these the serum levels of our sodium. I also need you to remember that these patients may be in very critical condition. Some of them may not be awake. They may be in a coma, okay? So we're trying to make sure that we're treating them as soon as we can before the condition gets worse and before their alertness becomes more altered, okay? So strongly consider for those who have moderate to severe hyponatremia with a documented duration of less than 48 hours. Our treatment options are listed below. And then always remember, we talked about this, the water restriction, okay? We want to make sure that we can accurately account for their ins and outs, their I's and O's, is what you'll hear people say. So we always want to make sure that we can account for them and see if our medication is working correctly. Treatment, this is going to be a majority of your patients. This is chronic asymptomatic, so they've been this way for a long period of time or they don't know when it occurred. Fluid restriction, vasopressin 2 receptor antagonist, okay, your conivaptan, your tolivaptan, understanding that your conivaptan is treating everyone equally, okay, B1 and B2, whereas your tolivaptan is more so on the B2, so looking at that, your kidneys, okay. Black box warning for your tolivaptan is where that belongs, where you got started in the hospital. Understanding that your tolivaptan is also a PO option versus your conivaptan is IV only. Oxytocin, stimulating that lactation in those patients. We use it a lot when we're talking about inducing pregnancy, okay. Postpartum bleeding, you can see it there as well. So just understanding when you can use this, definitely an IV medication, understanding that metoclopramide is a medication that you can use off-label to stimulate lactation in women, but because of the side effects, a lot of patients or a lot of providers won't give metoclopramide for this, but this is an option to use for those patients. See that it's not something that they have to use for a long time, considered safe, but there's still concern of those CNS effects that we can get from it. Going to our diabetes. Oh, got it. Almost there. All right, so remember we were talking about our type 1, they're presenting, they're usually insulin dependent, their beta cells have been shocked, they're gone. Whereas our type 2, more so these patients, is lifestyle issues that have caused them to become diabetic. Not always, most of the time. So you see a lot of this is progressively them not producing enough insulin and progressive resistance to insulin. These are your definitions, just understanding kind of a general idea of what's happening when you see a person with type 1 versus type 2. I don't need you to diagnose. This is just for you to see what's going on, okay, in your patient. Insulin preferred medication, especially if a patient is pregnant. It does cross the placenta, but if a patient has diabetes and we need to treat them, you will sometimes see that providers will use this sliding scale, insulin sliding scale, to make sure that our patients are still controlled. You have your regular, rapid, NPH insulin. We have long-acting. A lot of people don't like to use the long-acting because you will have to wait for it to completely wear off. And if that patient, by chance, gives themselves too much, they're going to be in that hypoglycemic state. which we don't want them to be in, so that is why you don't see it used as often. For your other medications that you can see used when we're talking about our gestational diabetes, metformin and glyceride, again, not something that is used a lot. We will go to our insulin usually first, but you can see them if insulin is not something that we chose to use in that patient. Hypoglycemia, here are all of our risk factors, so make sure that you know these. These are the ones where the patients are going to be predisposed to being hypoglycemic a little bit more than a normal healthy person may be. When you're looking at the different stages of hypoglycemia, stage 1 is like, you're less than 70. Remember 70 as our number for hypoglycemia. You're less than 70, but you're above that 54 mark. When you're less than that 54 mark, you're level 2. And then when you're like having altered mental status, or they lose consciousness, that is level 3. It's the F word time. Somebody needs to be there to help them because the patient is probably not going to be able to inject themselves with the glucagon. If they are in the hospital, you probably have some the D50 that you can give to the patient. So that is what this is telling us. Make sure that a patient that you know that is often hypoglycemic, that they have glucagon available and that they know how to use their injector, okay? And that the caregiver also knows how to use the injector if there's someone that is in the home with them, just in case they hit a level 3. DKA versus HHS, understanding that our patients with DKA, usually they're going to be our type 1, whereas our HHS are usually our type 2, understanding that they are going to have the ketones with DKA versus with your HHS. You do not onset very quickly with our DKA. Our HHS is usually happening over a longer period of time. Their glucose levels are very high, usually over 600 when we're talking about our HHS. This was just showing you in the middle what we were going to need to do to help our patients who had DKA, how we were going to be giving them. So with your IV route, you're giving them their the IV bolus, okay, of their insulin, and then they're going to do a continuous infusion. And then we're trying to get them to fall within that 10% in the first hour, and then if not, we can give another bolus dose and then continue that that continuous infusion over time. So what I'm expecting for you to know is that you can do a bolus with a continuous, what our goal is, which is trying to get them to fall at least less than that 10% in the first hour. If not, rebolus them. Or we have where we're giving them this larger unit per kilogram per hour as a continuous infusion to still get them to that same less than 10%. And if we can't get them to that, we are going to bolus them. Make sure that their potassium levels are less than 3.3 before we start the insulin. Because if we don't, it can worsen our hypokalemia that those patients are having. Insulin, this was just the way that it works. One of the big things that a lot of people will complain about, hypoglycemia, and then also weight gain. Weight gain is a very big deal when you're talking about insulin. So when we have our patients who are already overweight, if we can give them, especially in our type 2 patients, if we can give them a medication orally that is weight neutral or that may help them lose weight, it will offset or decrease how much insulin we're having to use. We also don't want to cause insulin sensitivity we don't want to cause insulin resistance. So that is also why, if we can, we will try to either decrease how much insulin we're giving to the patient or try not to keep them on it for give another medication to help them kind of control their diabetes. This was our different our bolus basal dosing that we could do. I needed y'all to understand which ones fell under rapid, short, intermediate, and long. Okay. Also understanding that we have some mix that are available where your rapid will have protamine next to the name, and then it will be mixed with a NPH, or your short will be mixed with one of your NPHs. We never mix our long acting. Never, never, never mix long acting. These were the different types of needles that we could give our patients. Make sure that if you are prescribing insulin, you are prescribing needles. If you are prescribing an insulin pen, you are prescribing the needles. They still need needles. They will always need needles. Give them test strips. Make sure that their test strips don't expire because test strips do expire. Have them bring in their machines to you sometimes so that you can see what's going on. With this, understanding that the U500 was specifically for your concentrated insulin that we had. It is not used for your regular insulin, okay? Use a U500 syringe for U500, okay? These were your different insulins that were available to you, separated by if they were bolus or if they were basal. And then I needed you to understand this entire table. Okay, so like when is it on? I don't really care about the peak, but I want you to know when it onsets. I want you to know the, actually, know the table, because it's going to be too much. Know the table. Y'all are like, it's too much to know the table. Know the table, okay? And understand there was a picture in the regular slide deck, I don't think I included it here, that shows you those different peaks and stuff so you can see kind of how they're working. Understanding with your long-acting, you don't have a peak. Once it gets in there after that injection, it is just carrying them throughout the day, just trying to mimic a basal insulin dose for those patients throughout the day. Our rapid, know when you're giving it. I guess that's a better way to, it's still the same thing, y'all. You just have to know it. I was trying to see if there's a way around it, and it's not. Appearance, it's clear, okay? And then a lot of people are having questions about the clear versus the cloudy, just making sure that you would put your clear into your cloudy. It's essentially, you're making your own mixed insulin, is what that is saying, okay? Not something that is done often anymore because the manufacturers are not making it for you. These are your short-acting, these are your mixtures, okay? So you see how, you see aspartate, which we normally think for our rapid, but because of the protamine, that's what's making it last a little bit longer, okay? I just need you to be aware of the names. I don't need y'all to know anything else from here. I need you to know that there are mixtures that exist, okay? Our intermediate is our NPH. Our long, you have your glargine and your detamere. All of these, you're looking at when am I taking it in relation to food? Do they have a peak? Usually, if you remember when you're taking it with food, you can kind of understand when your onset is, okay? If they skip a meal, when we're talking about their bolus dosing, you can skip that bolus dose because they have the basal usually occurring in the background. This was how we were going to implement, so this was a ballpark based off of that patient's weight. So I put it in here, the 0.5 units per kilogram. That was going to give you your total daily dose of what was happening for our patients. And then remembering to split it by the 50%. You'll have your basal dose, and then your bolus dose will be divided by how many times that patient is eating that day, okay? This was for you to correct. So they check their blood glucose level is too high. This equation is helping them know like what additional units are going to be needed. You are going to be the one who does this for them and gives them like that sliding scale sheet for them to know what they need to do to correct. So the example was in there. You have their current blood glucose level. We got what their goal was, which you will be given their goal. You use the correction factor that you have and you'll get that dose. Remember the rule of the 1500 versus the 1800, depending on if you're using regular insulin, which is 1500, versus your rapid insulin, which was the 1800. Insulin to carb ratio, I'm going to celebrate, all right? What am I needing to do? This is what this one is telling us. Regular insulin and rapid insulin has different carb coverage that you'll need to know. So understanding the 450 over the total daily dose versus the 500 with your rapid over the total daily dose. One insulin, roughly what this is showing you is that one unit of insulin is covering every 15 grams of carbs. Okay. The more obese, the more resistant that they are. So you'll see that most of these people will need more insulin. That's why we always try to control their weight. If they're smaller, you'll see that they probably use less insulin because they have less insulin resistance. That was giving you an example. This was just an example telling you anytime that you're checking your patient's logs and you see that their blood sugar is off, it's usually because of what happened to the dose prior. So that is what you're going to adjust the next day. You can't do anything about it, right? Because they've already had that dose. So this is what you're doing the next day for that patient, depending on if they're high or if they're low. Looking at your different metabolic syndromes and understanding, you know what, I don't think is in here that I need y'all to know. The different effects, the Somogi, I need y'all to know that. My bad, it's not in here. Y'all know which slide I'm talking about? I think in the actual slide deck, it was after this one. Okay, if y'all want me to, I will re-upload it with that in there. I get mad when I mess up something else. Okay, this one is just talking about type 2, what you will see and what their definitions are. So they have to have at least 3 out of 5 of these symptoms for us to say that they're a type 2 diabetic patient with the metabolic syndrome. Okay, this was the algorithm that we went over today. And I'll pull up that slide at the end so y'all can see which slide I'm talking about that needs to go in the review. This was the summary of all of your different meds. So again, good review for you to see everything, to see their mechanism, to see some of the big precautions as you go through these. And then this is all of the stuff that we went through today, so I'm not going to do it again, and we got 1 minute left. Let me show you the slide. Let me show you. Hold up. Versus the Somogi effect. And when we were talking about the fact that with our dawn, so at the end, both of these patients in the morning, when they wake up and they test, they're going to have hyperglycemia. The difference between the two was that we saw that with our Somogi effect, Somogi S, while they were sleeping, they had hypoglycemia in the middle of the night. And they will wake up to test around 2 to 3 in the morning to see if they have the Somogi effect. So if they have the dawn phenomenon, right, they're not getting enough of that basal insulin dose, so their body is trying to produce insulin on its own. So that's how they end up with the hyperglycemia. Wait, insufficient use. Said that wrong. Scratch that. Because we didn't give them enough, they are hyperglycemic. We didn't control for what they had for dinner or that night. So we don't have enough basal for that night. Whereas when you're talking about your Somogi, okay, I gave them too much. They went hypo, so their body tried to get them back into a normal glycemic range. And so that's how they end up hyper in the morning. Okay, so one, we're going to increase our evening basal dose because we didn't cover them enough. Whereas the other one, we're going to decrease the evening basal dose because we're giving them too much and we're making our body now work to catch up from what we messed up. Okay, so that is the difference between the two. Somogi, they're asleep. Somogi, we need to decrease our basal at night. And then go through your practice problem. Remember that the answer was C. I know sometimes we get, and if y'all need me, call me. I'm around, text me. Do we have another class that was supposed to happen?
Not this week, no.
I didn't have another block?
Nope, unchanged this week, no.
Okay, good. All right, so I will be back Friday still, and they moved us from the 3 to 5 block to the 10 to 12. So that will not be covered, like that is not exam material for this exam, but it will be taught to y'all on Friday. Okay. Text me if you need me.